White lesions of the oral mucosa may represent non-keratinized lesions or may indicate the presence of pathological keratotic lesions. Benign oral keratotic lesions are distinguished from oral keratotic lesions that are actually or potentially malignant. Keratotic lesions are pathological lesions in the form of hyperparakeratosis or orthokeratosis. We have seen that some mucous membranes are physiologically keratinized. These are mucosa which overlie bone. The mucosa of the palatine vault and the mucosa of the attached gingiva. Apart from these areas, the oral mucosa is not physiologically keratinized. Leukoplakia is a white keratotic plaque that is idiopathic or associated with tobacco use. More recently, the betel nut has been included in the definition of leukoplakia as its carcinogenic potential has been demonstrated. The diagnosis of leukoplakia is an exclusion diagnosis based on clinical examination and biopsy. Of the exclusion diagnoses, the major and most common form of pathological keratinization is frictional keratosis, which is often observed in relation to a dental prosthesis that is rubbing against the mucosa. In exceptional cases, traumatic keratosis may be chemical in origin. Here, it involved a patient with halitosis who repeatedly used mouthwashes with perfume. Lichen planus is one of the exclusion diagnoses for leukoplakia. Early lichen planus is expressed in a punctiform pattern of keratinization, which will progress to take on a networked appearance. Lichen planus may be idiopathic or may fall into the category of a lichenoid reaction, most frequently a contact lichenoid reaction relating to a dental prosthesis. However, the frequency of lichenoid drug eruptions should not be overlooked. A few examples of keratotic lichen planus. The photo on the left shows a punctiform appearance of lichen, which will progressively form striations between the papules and take on a more iridescent appearance on the border of the tongue. On the dorsal surface of the tongue, the lichen manifests as white plaques which correspond to the fusion of filiform papillae. Lichen planus and lichenoid reactions may develop into squamous cell carcinomas. Carcinomatous transformation is rare, below 1%, but involves both lichen planus lesions and lichenoid reactions. Lupus is a rare lesion of the oral mucosa. It is often confused with lichen planus lesions. The presence of cutaneous or generalized lupus often allows a connection to be made between the oral lesions and the lupus lesions. Nicotine stomatitis is specifically a lesion of the palatine vault that is caused by smoking tobacco and by the heat that results from tobacco use. This lesion manifests as a punctiform erythema linked to inflammation of the ducts of the minor salivary glands. This erythema is often associated with a peripheral superficial keratosis. There are different clinical forms that are purely erythematous or papillary. Nicotine stomatitis lesions do not have a malignant potential. They have, a priori, no potential to progress to squamous cell carcinoma, unlike leukoplakia. Papillomatous lesions correspond to a vegetative growth of the oral mucosa, most often keratinized. They are a mucosal variant of cutaneous warts or genital condylomata. They are lesions which may be linked to infection by non-oncogenic strains of the HPV virus, 6, 11, 24. so the lesions involved are a strictly benign, but exeresis is strongly advised because of the discomfort they cause. Leukoplakias. They therefore correspond to a mucosal keratinization that is idiopathic or present in a patient who smokes. Once the other causes of keratosis have been ruled out, homogeneous leukoplakias are distinguished, which may be extremely fine as on the floor of the mouth or much thicker as on the dorsal surface of the tongue. Leukoplakias may also have an inhomogeneous appearance, combining thick nodular plaques with plaques that are thinner or have a punctiform appearance against an erythematous background. This is referred to as erythroleukoplakia. These inhomogeneous leukoplakias are much more suspect than homogeneous leukoplakias. The presence of leukoplakia linked to the use of snuff or chewing tobacco, which is often deposited in the oral vestibule, should not be overlooked. These practices are little used in Europe, but conversely are very common in Southeast Asia. Observations of this type of lesion in France are often in the migrant population. There are more specific forms of leukoplakia which do not match the original terminological definition. For example, syphilitic leukoplakia, which is observed in secondary syphilis. Here, the patient presents with leukoplakia type plaques of the oral mucosa and very often with identical lesions on the skin. These lesions are currently frequently observed in HIV-positive patients. Leukoplakias must be considered lesions with a potential for malignant transformation. This potential for malignant transformation is around 10%, knowing that the inhomogeneous forms are 7 times more likely to transform than the homogeneous forms, that leukoplakias larger than 200 square millimeters are 5 times more likely to transform than smaller lesions. Finally, it is important to run tests to determine whether the leukoplakia is dysplastic, as 20% of dysplastic lesions will undergo carcinomatous transformation within a 5-year period. Leukoplakias associated with an absence of smoking, a non-homogeneous character, and a site on the lateral border of the tongue have a higher risk of malignant transformation. There are clinical forms of leukoplakia that are extremely unfavorable. In particular, proliferative verrucous leukoplakia, also called verrucous carcinoma, which manifests as a multifocal leukoplakia or as very hypertrophic forms. Anatomical pathology tests will, in this case, enable confirmation of the diagnosis. A clubbed papillomatous appearance will be detected, very often without associated dysplasia. These leukoplakias must be considered low-grade carcinomas. A biopsy should be taken in all cases of leukoplakia. This biopsy must take account of the different aspects of the basic lesion, knowing that the basic lesions most at risk are red and white lesions or distinctly red erythroplakic lesions which stand out against the healthy mucosa. The biopsy will be investigated for the presence or absence of dysplasia, and in particular for invasive carcinomatous transformation. Treatment of leukoplakias is based on the very first instance on cessation of smoking. When this can be obtained, a regression of lesions is rapidly observed. Leukoplakias must be treated surgically when they are small, exeresis with a blade is recommended. If they are larger than a few square centimeters, laser vaporization is indicated after taking a biopsy to check for the absence of a carcinomatous transformation. For large proliferative verrucous leukoplakias, drug treatment with weekly perfusion of methotrexate may be recommended and frequently enables eradication of this type of lesion, which routinely develops into invasive squamous cell carcinoma. Finally, mixed treatments combining surgery and laser vaporization can be offered, depending on the size and thickness of the lesions. Actinic cheilitis. This is a common lesion which principally affects men over 45 years of age. Actinic cheilitis manifests as a white lesion on the upper lip, which takes on a keratinized elastotic appearance with loss of the vermilion border boundary between the lip-stroke cutaneous covering. There are often ulcerations in the active forms. Actinic cheilitis may progress to squamous cell carcinoma. Treatment is necessary. Treatment of generalized actinic cheilitis will be based on vermilionectomy, which consists in the exeresis of the entire vermilion zone of the lip. When it is more localized, laser vaporization treatment may be indicated. In conclusion, when dealing with a keratotic lesion of the oral mucosa, a clinical and, in most cases, provisional diagnosis must be made, followed by analytical tests in the anatomical pathology laboratory.